Good morning, everyone, and thank you for joining us. My name is Stacy Bakis, and I'm the Director of Leadership Giving and Engagement at St. John's University. Today, we have Dr. Andrew Clair, who will conduct a live CE webinar on the COVID and vaccines. Some housekeeping rules before we begin. If you have a question, please submit it on the bottom right to host, and Dr. Clair will answer them at the end of this presentation. Also, to receive CE accreditation, you must remain on for the entire hour. Now, I'm excited to introduce Dr. Andrew Clair. Dr. Clair has been making presentations at public libraries across Long Island on the science of COVID-19, just the facts. The presentation provides details on issues not readily available in the media or typically made public, including why the virus is so contagious, who is most at risk, how the pandemic has revealed healthy disparity bias, vaccine development, and the new technology that has led to unprecedented effectiveness and speed to market. On February 4th, he made a presentation and served as a panel member at New York State Senator John E. Brooks' COVID-19 vaccine informational webinar, and in March is scheduled to serve as a panel member and make a presentation for New York State Senator Kevin Thomas from New York's 6th District. Dr. Clair has his doctorate in pharmacology from the Graduate Division of the College of Pharmacy and Allied Health Professions at St. John's University. Welcome, Dr. Clair. I will hand the webinar controls over to you now.
Stacy, thank you so much, and hopefully everyone can hear me well. Stacy, you can hear me well?
Yes, I can.
Okay, perfect. Okay, good morning, everyone, and thank you so very much for joining me today on this live webinar, The Science Behind COVID-19 and Vaccines, Just the Facts. Before I get started, I really want to reach out and thank Stacy for all the work that she's done in setting up this webinar today. And I also want to acknowledge Rachel O'Reilly and Bill Malone, two colleagues that I've worked closely with over the years at St. John's as well. All three make an important contribution to the work that they do and to St. John's in general. So thank you to Stacy, Rachel, and Bill for all of your help in getting us up and running today. I have one disclaimer. Please note that the purpose of this presentation is for educational purposes only and should not replace independent professional judgment or be used as a substitute for discussions with your healthcare professional. We have a very ambitious agenda today. I want to review with you kind of the history of pandemics, get into the biology of the novel coronavirus that causes COVID-19, what specific characteristics of this virus make it very, very unique and also highly contagious. Then we want to talk about the variants that are now showing up in the United States, including on Long Island, based on genetic diversity and really the inevitability of the spread of COVID-19. We also want to talk about the symptoms of this disorder, long-term consequences, and who is most at risk. We'll then get into the vaccines. I want to talk to you about clinical trial data that's really been instrumental in proving not only effectiveness but also safety, and then in fact get into safety and effectiveness and also what that means to people who have underlying conditions. We'll finalize our presentation today with treatments that are now really saving lives if you are hospitalized. And then lastly, go over the advisory committee process and FDA authorization. For those of us who may be a bit skeptical about the speed by which these vaccines came to market, the advisory committee and the FDA authorization process should allay those fears. And then finalize, as Stacy mentioned, with a question and answer period. I also want to mention that despite the best efforts of so many scientists, we still don't have all the answers to the questions surrounding the novel coronavirus that causes COVID-19. And the reason is in part because things just keep on changing. We thought the original virus was here and we understood it, and now we have variants. So things continue to evolve in this space. When I give a talk like this, I really always have to think about the people that have been lost. More than 2.4 million people have died as of today. I just checked this morning. 2.4 million people have died as a result of COVID-19. This is an astounding number. It is a tragic number, and it is absolutely catastrophic. When you're a scientist and you give a talk like this, you tend to get into facts and figures, and you put up a number like this, and it's almost so astounding that you forget that this represents a single individual, 2.4 million single individuals who leave behind families, family members, brothers, sisters, spouse, etc. It's mind-boggling, and it's deeply, deeply sad. And when I think about this, I know my thoughts and prayers go out to everyone impacted by this global pandemic. We now have passed 110 million cases globally, and you can see with the map on the left that that the virus itself and the pandemic itself is virtually everywhere around the globe, north of 110 million cases. And yet, 1 year later, since the initial pandemic, I have a personal story of bumping into a person who said, I had COVID back in February, and my symptoms were so mild that I have to say I take COVID over the flu, which made me really sick any day of the week. And then I read about a person with severe COVID-19 illness who was about to be intubated, and that person reportedly said to the nurses administering to him, I know this is not COVID, it's just a bad case of the flu. And this is a fallacy. This is a mischaracterized argument. This is not based on fact. It's a fallacy. And part of the myth of COVID-19 is based on these two pieces of anecdotal statements. And as you'll see throughout the presentation, I think it's very important that we, understand the mythology of this disease, but also make sure that we understand the facts of this pandemic. Right now, we're at 2.2, a global death rate of 2.2, again, globally, and 1.7% a U.S. death rate based on the proportion of deaths versus the proportion of cases. And again, this is the latest information as of today. When I was putting this presentation together, I was thinking about my dad. And the reason I was thinking about him was because he was born in 1918. And as you'll see, I believe on the very next slide, 1918 was the year of the Spanish flu that was devastating across the globe. My dad was born into that pandemic in 1918. His parents survived the pandemic. I got to meet them as a young boy. And my dad's brother and sister also survived the pandemic. And it's just kind of ironic how history repeats itself as we now are living in real time through the next major pandemic, literally 100 or so years later. history does repeat itself. We've been here before, and we will be here again, unfortunately. From 1347 to 1359, the Black Death or the bubonic plague killed 200 million people across the world. It originated in rats and spreads to humans via a bacterial-infected fleas. In 1520, smallpox appeared. That led to 56 million deaths due to the variola virus. And then the aforementioned 1918 to 1920 Spanish flu, which killed upwards of 40 to 50 million people, and in some resources that I've looked at, the number is probably much, much higher. It was caused by the H1N1 influenza virus, which was avian-borne, actually was transmitted through birds. In 1541 to 1542, the plague of Justinian, which probably is thought to have led to the downfall of the Roman Empire, that caused 30 to 50 million deaths, and similar to the bubonic plague, was spread to humans from rats through plague-infected fleas, bacterial in origin. Of course, 1981 to the present, we're dealing with HIV and AIDS, another pandemic, 25 to 35 million deaths so far due to the HIV virus. And here we are in 2021 dealing with the 2019 COVID-19 pandemic, which has cost us 2.4 million deaths so far. And as you'll see in a couple of slides, bats and pangolins, which are a type of scaly anteater, have been identified as the probable host of this coronavirus and been passed from bats and/or pangolins to humans. I put this slide up to give you a relative sense of the size of COVID-19 and the novel coronavirus. You can see it over here, and you can see in comparison just how small this virus is. You can see up here that a particle needs to be less than 10 microns in order to enter the respiratory tract and then get into the lungs. The novel coronavirus is 0.1 to 0.5 microns, well within the range of being able to get into the respiratory tract of humans. It's also important to note that a virus this small is easily transmitted through the air, getting into wind currents and then being able to infiltrate through into the respiratory tract. So not only can it make easy entry, but it also is airborne. When I put a slide up like this, many people are kind of amazed that viruses are in fact the most abundant life form on Earth, but they're not really alive. They kind of live. They don't respire until they actually enter the human body and then enter a human cell. And I want to highlight the spike protein over here and on the model of the novel coronavirus. The spike protein gives it the name of corona equal crown, of course. And this spike protein is really important because it is this target that the vaccines and several treatments have attacked in terms of being able to neutralize. The theory being that when the novel coronavirus tries to make entry into the body and does, and then enters into the human cell, it enters in via these spikes that almost latch on to the ACE2 receptor, which is the dominant way that the virus, more on that in a couple of minutes, that the virus is able to enter the human cell. So by attacking the spike and knowing the genomic sequence of the spike protein, the vaccines have actually, all of them, kind of highlighted that, and especially the two that are currently approved, the Moderna and Pfizer vaccine. Now we're dealing with the variants, and I do want to talk to you about that during the course of this conversation today. COVID-19 is definitely a new disease. It's not previously been seen in humans, but coronaviruses have been well established for many, many years. In fact, the human cold is a type of coronavirus. The COVID-19 symptoms range from mild, virtually no symptoms, or being pre-symptomatic to severe. And I've highlighted the range in particular because this has led to the mythology of COVID-19. How is it that some people get a relatively almost no symptoms whatsoever? They test positive, they do have it, and they have a couple of sniffles. They have a mild respiratory illness. But what makes it so diabolical is the fact that many people, hundreds of thousands of people, suffer from the severity of the illness. And we also know how easily the virus can spread from humans to humans. This virus, COVID-19, is officially known as SARS-CoV-2, severe acute respiratory syndrome. Because first and foremost, it is a respiratory illness, but we now know that this disease can impact every major organ system throughout our body. Before we go into that, I do want to kind of show you the schematic of the 4 structural proteins that really make up the bulk of the COVID-19 virus. It consists of approximately 30,000 nucleotides, which makes it one of the biggest in terms of nucleotides coronaviruses that are out there. And those nucleotides essentially code for the spike protein, which, as I mentioned, mediates attachment to the cell, the membrane protein, which consists of a protein that is really the central organizer for viral assembly once it enters into the human host cell. The nuclear capsid, or N protein, aids in replication. And finally, the envelope protein, which really helps in terms of viral host interactions. Again, what essentially happens, and I'll show you this in a moment, is this interaction between virus and host is really what leads to the one thing that this virus wants to do beyond anything else, and that's to replicate. And this is how it basically does it. These over here are electron micrographs of the virus actually in the cell, and same here, both pre-fusion as well as post-fusion within the cell. And what's really very noticeable are the spikes in particular. And this is how it does it. The SARS-CoV-2 virus, the novel coronavirus, gains entry into the cell. It then fuses with the membrane and releases viral RNA. The virus essentially capture machinery uses the ribosomes to translate those viral RNA into amino acids. The amino acids and the RNA then start to replicate, and at this point, the initial virus that's going to eventually release from the cell enters into the cytoplasm. Here, once again, the virus undergoes translation via hijacking the endoplasmic reticulum and the Golgi bodies. What that does is actually precipitate and produce the membrane protein, the spike protein, and the envelope protein. This is then enveloped into a type of vacuole, and then the virus is shed out of the cell and starts its relentless attack through the body. The intensity of the infection is captured on this slide. You can see, as you know, lining our bronchial tubes and bronchi in general are respiratory cilia. These are the flagella-like projectiles that move microbes and other particles up out of our lungs to be expectorated or to be swallowed. And this micrograph shows in red how ubiquitous the coronavirus is in terms of invading the cilia of the human lung cell. So it's very, very obvious how intense this infection can be. And the most common symptoms that are now associated with COVID-19 have now been characterized into those individuals who are asymptomatic or pre-symptomatic, those who test positive but display no symptoms whatsoever. Mild infection really consists of upper respiratory issues, classic fever, fatigue, pain, etc., and also digestive symptoms. So it works down from the respiratory tract into the GI tract, and that can deliver nausea, vomiting, etc. Moderate infection now consists of pneumonia, but no obvious breathlessness, which then can develop into a severe type of pneumonia where breathing becomes very, very difficult. And then finally, the people that end up in the ICU unit who are critical have acute respiratory distress syndrome, or ARDS, which can also develop into shock, brain implications, heart implications, clotting difficulties, and acute kidney injury. This is why at the height of the pandemic in New York City, doctors were discovering very much kidney shutdown, and they weren't quite sure if it was due to the clotting that was occurring upstream or if there was a direct effect on the kidney, and it was really due to both aspects that was leading to this critical issue with kidney involvement. As I said, there is no organ system within the body that is spared the relentless onslaught of this virus. It is a lung disorder, so pneumonia is where it starts. It can then infiltrate the brain, strokes, seizures, brain inflammation, and brain fog. Eyes are impacted with conjunctivitis and other eyelid issues, including inflammation of the membrane of the eyelid. Anosmia, or loss of smell. I know a colleague who was infected back in February of last year and still had not regained his sense of smell. Already mentioned about the heart and blood vessel implications, clots, heart attack, and inflammation. And then on the liver and kidneys, liver enzymes are clearly elevated, confirming impairment and liver damage, and same with kidneys. Kidney impairment and damage are also being demonstrated, as mentioned before. And then finally, as it works its way from the upper part of our bodies into the intestine, nausea, vomiting, and diarrhea. As I said, there's no organ system that in theory and in reality are not impacted by the novel coronavirus. But we've been here before. SARS and MERS were both caused by a coronavirus. SARS back in 2002, MERS back in 2012. SARS, severe acute respiratory syndrome back in 2002, and MERS, Middle East respiratory syndrome in 2012. SARS originated in southern China, MERS in Saudi Arabia. And the hosts are bats for the novel coronavirus. Bats are, interestingly, the second most populated mammal on the face of this earth. Rodents are number one, followed by bats. And there are more than between 900 and 1,200 species of bats on Earth. With SARS, it leaped from bats into a civet animal, which is a cross between a cat and a mongoose. And before the pandemic was finished, over 8,000 infected, 774 deaths. Thankfully, no deaths in the U.S. MERS pivoted from bats into camels and then infected over almost 2,500 infections, over 850 deaths globally, 2 deaths in the U.S. And what this really highlights for me was the fact that back in 2012 and 2002, 2003, there was much better coordination between the U.S., the CDC, and the WHO. And what they did was they really got people infected into quarantine, started with supportive therapy, and really was able to disable the virus from spreading globally. So really, any death, of course, is a tragedy, but compared to where we are with COVID-19, you can see how well WHO and CDC were able to coordinate activities and really limit the spread of this virus. But COVID-19 has really been identified as started in the host bat or the pangolin. Pangolin being a type of spiny, if you will, anteater type of animal. It has either leaped from bats or pangolins into humans. And the culprit is human encroachment. As humankind has spread more and more throughout the world, there is really no area on this planet that human beings have not started to infiltrate. And human encroachment has meant that human beings are now coming in contact with animals and species of animals that they've not previously been in contact with. And when that happens, human beings, as we know, will oftentimes, based on cultural requirements and cultures that have existed for literally thousands of years, eat these animals. And eating an animal that is infected, for example, with the coronavirus is actually fairly safe as long as it's cooked. But it's actually the handling that comes before eating, the killing, skinning, butchering, that's highly risky. And that's how these viruses leap from animals into human beings. I wanted to get into a bit around contagiousness. Contagiousness of viruses is based on what's known as the R0 number. And this is essentially the capacity of the virus to reproduce and the capacity to obviously spread. If it's reproducing, it's going to spread. If the R0 number is less than 1, then what that means is that each existing infection is causing less than 1 new infection per person. Let's take a look at COVID-19, the 1918 Spanish flu, and then the seasonal flu. The R0 number for COVID-19 is typically being described in the medical literature as between 2 to 3. But based on the variants, some people are starting to think that this could be as high as 5.7. Spanish flu, the R0 number 1.4 to 2.8, and the seasonal flu 1.3. The case fatality rate is so far for COVID-19 around 2.2%. For the Spanish flu, it was greater than 2.5, and the seasonal flu less than 0.1. Total deaths are, as you saw before, 2.4 million thus far for COVID-19. There were between 50 to 100 million deaths globally due to the Spanish flu, and tens of thousands of deaths last year, 24,000 to 62,000 due to the flu. So what do we have here? We have COVID-19 as potentially the highest R0 number, higher than the Spanish flu. So more contagious than the Spanish flu, but less lethal. Less lethal. So there's an interesting paradigm going on here between contagiousness and lethality. And without getting too far into this, and actually I'll reserve what I wanted to say because it could be a little bit long-winded, and we have a lot more that I want to cover. If you do the math and you take the infection rate of COVID-19 as being that outlier number of 5.7, that means that if 100 people would infect literally 570 other people, just do the math, that 570 goes to 3,249, and you wind up with 100 people infecting over 3.4 million people, 3,429,576 people being infected by a highly contagious form of COVID-19 with an infection rate and reproductive rate of 5.7. Look at that number. This answers the question of why this is so contagious and why we're seeing such a dramatic rise in cases on a daily basis. A word or two about the variants. Well, variants are being caused by genetic mutations. We know of these types so far, the UK, Brazil, and South African variants. And now we're hearing something about Southern California having a particularly new type of variant. Why do variants occur? Because of adaptive evolution. Whether or not they're more contagious, whether or not they're more lethal, and not on this slide, but certainly on my mind, is what about the vaccines? How can will they be adaptable and be able to handle these new types of variants? So these are unknowns. One thing we do know, that if you stop the spread of COVID-19, then you definitely impact the mutation rate, and you are going to lessen the impact of the variants. It's simple. Less virus equal less mutations equal less variants. So this is why it's so important that we stop the spread of COVID-19, whether by social distancing, whether by washing our hands, whether by being locked down, and obviously the vaccines will make a major impact in slowing down the spread and hopefully getting to what's known as herd immunity. Finally, with variants, we now have just an article that I read the other day where two variants may have merged into a heavily mutated type of coronavirus. There's something going on in California where the UK and California variants are actually creating what's almost like a mutated hybrid. And we don't really have any information so far on what this could mean in terms of another variant to really potentially be dealing with. Who's most at risk to a severe outcome, and why is that so? Well, there's two types of vulnerable patient populations. There's the older patient populations and those with underlying medical conditions. And those underlying medical conditions are what, we're all pretty familiar with. I highlighted obesity in men because people that are obese actually have been found to have a lower functioning immune system. And bad news for men, us men, is that men have a less viable, vibrant immune system than women. It's a simple fact of genetics, probably due to hormonal endocrine differences, but it is a fact. So older people and underlying medical conditions, including what's listed here, obesity in men is considered to be an underlying medical condition. Certainly obesity being a male, not so much, but still, again, having a weakened immune system. And we do know, obviously, that our immune systems do tend to weaken with age. No matter how good a shape you think you are in, our immune system do tend to weaken as we get older. Many young people think that this is a disease that typically won't affect them, and they're right to some degree. But you can see from this slide that the death rate by age of COVID-19 in the U.S., pardon me, based on some fairly early data, I haven't been able to update this, that 4% of people 14 and under up to the age of 34 years, so age 1 to 34, 4% of that patient population has died. That is not zero. That is 4%, and that is something that young people have to be aware of. Look at how it jumps from age 44 to 54. It doubles from 4 to 9%. And then obviously the bulk of deaths, as we all know, is in the elderly population, ages 55 to 85 and over, 87% of deaths in that category. Caution with children, very young children, and a Kawasaki-like disease described here, which is a severe multi-system inflammatory syndrome, vasculitis, etc. Children younger than 5 years old, it's a small number of cases. This is a picture of the impact of that vasculitis. There is this syndrome that has been seen in very young children. Also, back to kind of those teenager, younger population of sufferers, we do now know that heart complications have been found in really top athletes, that strokes have occurred in young individuals, again, COVID-19 related. And while we know that typically young people are less affected, unfortunately, they are more likely than adults to infect others. Now, whether or not they're around adults who are taking care of them or if there's something else going on. But again, young people are not immune to this disease. While it's typically less severe, it's not zero in terms of death, and they can spread the disease to older siblings and older parents, etc. COVID-19 has revealed the ugliness of racial disparities in the United States of America that has been here for years. I think that health experts have always kind of known about it, and COVID-19 has revealed it. We now know that racial and ethnic inequalities confirm that people of color have borne the highest burden of COVID-19 in terms of hospitalizations and deaths based on their share of the population. Why? Why does COVID-19 and racial disparities exist? Well, because typically Black, Hispanics, and Latinos don't always have access to COVID-19 testing. They often live in urban America, live in high-density areas. They often are exposed to pollution of urban centers around our country. Oftentimes, they either have a pre-existing condition that they are not aware of, or that for many reasons they aren't able to adequately treat. And while people like me were hunkered down in my house during the height of this pandemic, oftentimes Black, Latinos, and Hispanics, people of color, are the essential workers keeping our country running. These are the frontline workers who work on subways, the Long Island Railroad, driving taxis, in grocery stores. So many essential workers that when Governor Cuomo said everyone stay home, the essential workers had to go to work. There has been a racial bias in healthcare for years, and COVID-19 has revealed that ugliness. This has to be addressed, and God willing, it will be moving forward. Why did COVID-19 affect people so differently? For some, it's mild. Others end up in ICU units fighting for their life. This is such an important question. It's a question that scientists really are not completely sure about, but there are some theories. And one of the main reasons why some are getting a mild reactions, but others are fighting for their lives could simply be a matter of genetics. That there's a genetic component where the immune system is simply less able to fight the virus. And what does that actually mean? Well, genetically, some individuals who are ending up with severe illness are generating autoantibodies. These are antibodies that do the exact opposite of what they're supposed to do. They, instead of fighting the disease, they mistakenly target our own tissues or organs and cause severe illness and cause severe damage to those organs. And another aspect of the novel coronavirus is the cytokine storm. You start off with the virus, but because of a genetic abnormality, cytokines, which are proteins that help antibodies clean up and get rid of the viral almost detritus, if you will, that happens once your antibodies go to work. There's an overabundance of cytokines, a phenomenal onslaught of cytokines that actually, once again, attack our own organ systems. And this cytokine storm causes a phenomenal amount of inflammation. And this inflammatory response is actually, in many cases, what kills a patient with COVID-19. Starts off as a virus, ends up, though, being deadly due to this cytokine storm. What's the timing of this illness? Typically intubation 2 to 14 days, symptoms within 5 days after contact. If you get symptoms, you typically will see them by day 12. If you get infected, the spread typically occurs 2 to 3 days before the symptoms start. And this is why this illness is so difficult and, as I said before, diabolical, because you're actually spreading it pre-symptomatically. And this is why the spread has been so prevalent, or one of the reasons. And you're most contagious actually 1 to 2 days before you actually feel sick. So you don't feel sick, you're out in the public perhaps, spreading the disease. And here's the list of the order of symptoms. Typically, you start out with no symptoms. One of the first symptoms typically seen is fever, that then comes with, later on, cough, sore throat, headache, and muscle pain, followed by nausea, vomiting, and then diarrhea. Similar to what I showed you before with the march of COVID-19 throughout the body, kind of upper, moving to the lower body and the GI tract. Roughly 5% of patients who get infected are going to become critically ill, but some of these patients are experiencing long-term symptoms. These are the long haulers, and you can see just how difficult it can be for some individuals to get rid of all the symptoms, and they're listed here. I talked to you about a colleague who I know that literally a year later still has not completely regained any sense of smell. These cardiac issues and these decreased lung capacity, people that are no longer testing positive, they're 11 months post testing positive, they no longer have COVID-19, and yet they are having these long haul symptoms. But I'm particularly concerned about, even though people with COVID-19, about 80% of them get mild or are asymptomatic, what about what's going to happen to them down the road? It is still unknown what other yet to be determined complications may develop over time. We just don't have the information yet on COVID-19. So let's talk about vaccines and how it all happens. Vaccines start with giving a person a small amount of a harmless form of the disease. You're vaccinated. Your body now then makes antibodies to the disease. You now have antibodies. When you encounter COVID-19, you have the antibodies. Your body has already created them. You don't get sick. You're immune. And there are different types of vaccines: live, attenuated, similar to the mumps, measles, and rubella vaccine; inactivated or killed versions of the virus, typically the flu. And at the end of the day, vaccination means that you're mimicking the virus, you're activating the immune system, developing antibodies without being infected. Many people are concerned that the vaccines for COVID-19 were just done literally overnight. It's not true. We've known about human coronavirus since the 1960s. Scientists have been studying them, especially with SARS and MERS. And in particular, MERS was the condition of MERS started the early development of a vaccine. And that early development helped jumpstart the vaccine for COVID-19. Here's where we are today. We have 5 vaccines that are really getting the bulk of information talked about. We have Pfizer, Moderna, AstraZeneca, J&J, and Novavax. Pfizer and Moderna are messenger RNA vaccines. They're both approved, and their effectiveness is unprecedented. Literally 95%, 94%. To get a flu vaccine approved by the FDA, you have to have around 50% effectiveness. AstraZeneca's vaccine uses a different technology. It will allow for normal refrigeration, which is an advantage over Pfizer and Moderna. The J&J vaccine, which is probably next up, planning for a February 26th emergency use authorization, this is a single dose, which clearly will provide an advantage over the Moderna and Pfizer vaccine in terms of doses. And then finally, the Novavax vaccine, which is also a nanoparticle type of DNA vaccine, very, very interesting technology. This too will allow for normal refrigeration. So certain advantages all the way across. Having more vaccines available means less spread of the virus, means less mutation of the virus, means less variants. So a really positive sign here on the globe in terms of where vaccinations stand. But the most vital component of vaccines, all about clinical trials, and this is Pfizer's overall program, and it's quite interesting how this all came to pass. The Pfizer vaccine was really started as soon as they were able to genetically sequence the COVID-19 virus, and that began early animal studies. At the same time, they went on risk into advanced manufacturing, so they weren't waiting to manufacture. They started to develop a vaccine because they had the genetic sequence of COVID-19, and they went on risk and started manufacturing. That's why by the time it got the emergency use authorization, it was available in vials. These are the pivotal studies that were so important to get approval. It's all about phase 2 and phase 3. And then a lot of people are concerned about the safety of these vaccines. Well, right from day one, the Data Safety Monitoring Board was put into effect. This supersedes and doesn't override, but it's another it's another group of individuals that are constantly looking at safety. And then follow-up safety is also necessary even after a study is completed for at least 2 years. And you can see the numbers of patients in clinical trials. Pfizer, 43,000, Moderna, 30, 44,000 for J&J, and AstraZeneca, 30,000. Right from the debriefing document for Pfizer's clinical trial, you can see on the x-axis days after dose 1, and then cumulative incidence of the disease. If you take a look at this graph, you can see that the disease onset appears to occur similarly all the way up until day 14, where the curves start to spread. This means that the vaccine probably starts to safeguard about day 14 after dose 1, but you have to make sure. And it's really interesting how the incidence of COVID-19 infection were flat on the Pfizer vaccine, and looking on placebo, how they just exponentially increased. Don't forget, if you're lucky enough to be vaccinated, or if you've been vaccinated or about to get vaccinated, you need 2 doses of both the Moderna and Pfizer vaccine. No need to go through this. This, again, I think would allay any fears about Pfizer's safety monitoring plan, same for Moderna. Constant safety surveillance right after dosing, 1 month, 6 months, and 2 years, all the way out to 2 years to make sure that there are no untoward safety concerns. And this is the clinical trial data reported in medical journals for both Pfizer and Moderna, 90% effectiveness. Clearly, the technology has led, I'm confident, to the high degree of effectiveness. Safety advantages, no doubt, as well, and shorter manufacturing times. These vaccines are relatively safe. There's no question about it. But regardless, always consult with your doctor before you really take any new medications. I just think that's good practice for any of us. Even if you go and get an over-the-counter medication for your cold symptoms and you have high blood pressure, you should really talk to your doctor about getting them. A lot of them have phenylephrine in them that can tend to raise blood pressure. So COVID-19 vaccines, relatively safe. I think I have a slide to show you the safety record so far. But again, always consult with your doctor. There are CDC recommendations for, in a very small percentage of patients, to get a severe anaphylactic reaction. When you get your vaccine, you will be monitored for 15 minutes to make sure that you're not developing that. And typically people who might have been allergic to the flu vaccine or shellfish, et cetera. This is the this is the adverse event incidence rate post-vaccination based on the clinical trials of Pfizer, and you can see injection site reactions being the most common and on down the line. More severe adverse reaction, still relatively small percentage, more frequent after dose 2. And you're reading about this in the media. Dr. Fauci also mentioned that he got some symptoms of fatigue and kind of feeling a little bit under the weather after his second dose. I'm going to go through this relatively quickly. This is how the messenger RNA vaccines work. You understand the genetic code of the virus. You then can genetically create messenger RNA, which then codes for antibodies. At the end of the day, a vaccinated person gets the vaccine and the messenger RNA vaccine creates a message to the body to manufacture the antibodies specifically against the virus spike. If you encounter the virus, never is able to gain a foothold because of the antibodies, and you're protected. At the end of the day, these messenger RNA vaccines essentially neutralize the virus by obliterating those spike proteins. Messenger RNA vaccine didn't happen yesterday. Been studied for a decade or more. They don't contain a live virus at all. You have no risk of carrying the disease into the vaccinated person. No way that you're affecting the person's DNA because the vaccine or the messenger RNA never enters the nucleus of the cell. No impact on a person's DNA. It's a common question. But even after you get vaccinated, you are going to have to wear a mask because even though we know you are being prevented from getting the symptoms, you still could pass the virus on. We have no data on whether or not a vaccine inhibits a person from spreading the disease. Even if you're infected, you won't feel the symptoms. Don't forget, so that's one thing. And don't forget, the vaccines are 90 to 95% effective, right? Not 100%, so you're still going to have to wear a mask, even after vaccination. How long is immunity? No one's really sure. We think it's around 1 year. Treatments, very important. When this pandemic started, we didn't have these available. Now we do. Remdesivir is an antiviral. It's the first one approved for COVID-19. It is found to shorten the recovery time in hospitalized patients. It does not reduce COVID mortality. What does reduce COVID mortality because of that cytokine storm issue is dexamethasone. Dexamethasone has been around, for those of you who are old like me, since the 1950s. And here is an old drug, the only one found to reduce mortality. Why? Because of the ability to inhibit and reduce the cytokine storm as an anti-inflammatory. Monoclonal antibodies are going to play a big role in terms of treatment. Just yesterday, this article, or the day before yesterday, came out about prophylactic anticoagulation therapy now becoming a major issue with regard to clotting. Instead of waiting for those clots to occur, now they're using it prophylactically to really prevent morbidity and mortality. And this is a cohort study that confirms that data. When President Trump got treated for COVID-19, he went into the hospital, and these were the 8 medications that he got. He got dexamethasone, so those physicians were ahead of the curve, preventing the cytokine storm. He got the antiviral remdesivir to lessen the viral load within his body. He also got a synthetic form of monoclonal antibody from Regeneron, and then he got these other supplementary really vitamins and supplements for various reasons, none of which have been found to do anything with regard to COVID-19, of course. Aspirin, obviously, reducing the risk of blood clotting, an important part of the treatment phase. How do you predict a good and bad outcome? Probably through gene variants. This is a common theme that I get questions on. I'm afraid that I'm going to have a severe reaction, probably due to genetics, people being, as I said, more prone to that cytokine storm, and blood type. Blood type O people apparently have a better outcome than blood type A. There is some data to support that. Finally, for those people concerned about the FDA approval process, and that maybe the concern is the politicization of this virus, the advisory committee is a process that has been used and will be used and has constantly been used for approval of new and important medications and vaccines. They provide an independent view of data. They're scientific experts that typically come from academia. There's also a public voice that can be heard at these events. They vote on key issues, and Cuomo actually put his own advisory committee in place in New York State to really make sure that everything was comfortable based on his scientific experts. They voted unanimously and made a recommendation to FDA for the emergency use authorization process, which is how these vaccines have gotten onto the market. I love this quote from Madame Curie, obviously the physicist and person involved in radioactivity. Nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less. And this is my last slide, and I do just want to put up a partial list of references that were used to provide the data that I just made in this presentation. Stacy, I know I'm a little bit late, but I hope that I'm going to turn it back over to you, and I hope that we can have some questions and hopefully answers to those questions.
Great. Thank you, Dr. Clair. We do have some questions coming in. I'll start with the first one. Can you address the ACE2 receptors and virus tissue penetration and increase via antihypertensive therapy?
Yeah. I'm not sure the best way to complicated issue. ACE2 is ubiquitous throughout the body. It's not just on the blood vessels. It's not just in the respiratory tract. ACE2 is everywhere. And there was a school of thought that if you're taking antihypertensive therapy that binds to those receptors, that you might make yourself less prone to the disease, right? Because you're occupying the receptor with, let's say, an ARB or a drug that binds to ACE2, right? There's no data, and I've spoken to medical experts at the University of Texas where I have a relationship with. There's no data, and there's been some publications that support the fact that ACE2 receptor blockade does not, and through antihypertensive therapy, does not make you less prone to the disease. And it's kind of counterintuitive. I thought it might, but it in fact doesn't. So hopefully that answers your question.
Next question. Patients who experience no side effects after vaccination versus those who have severe, any difference in effectiveness?
I don't think so. I think that for people, like I said, fortunate enough to be vaccinated, the fact that you might have a mild reaction or a more severe reaction, be assured the vaccine is working. It could just be some susceptibility that you have. I know on various years that I get the flu vaccine, sometimes I get, kind of nothing, and then other years I get a big reaction to the vaccine. I don't think that I would think that a less severe reaction to the COVID-19 vaccine would be indicative of less protection versus more protection.
Next question. What happens to the effectiveness of the vaccine, let's say Pfizer, if there is a delay on getting the second dose? Recommended is 3 weeks apart. However, what if a patient were to get it 4 weeks apart instead due to availability? How would that affect the effectiveness of the vaccine?
It's a really important question. I don't have a great answer, but I'll give you some theory. After dose 1, based on the literature that I've read, you're about 50% vaccinated. You have about 50% effectiveness after dose 1. If you go a little bit long in terms of getting your second booster dose, pardon me, my concern would be that you want to, really just try and be on the date that they gave you. They give you that little card typically. Try and get there on that date. I wouldn't personally be over concerned if it was a day or two later. If it was a month or two later, I would definitely be concerned. Don't forget, the booster is how you get 90 to 95% effectiveness based on Moderna and Pfizer. So you want to take advantage of that by having the booster. 50%, approximately 50% after dose 1, 90 to 95% after dose 2. If there's a delay, I don't think it's going to be dramatic in terms of you being susceptible to being infected, but a few days I don't think would be an issue. Months, absolutely, you wouldn't want to do that. You must get the second booster, and you want to do it within a reasonable period of time based on the information that they gave you when you got dose 1.
Can you explain further the differences noted with blood type?
No, I can't, and that's why I didn't put it on the slide. It's very early with regard to the literature that I read, and I did not put it on the slide for this very reason. I definitely appreciate the very good question. I read about O being more protective, A not so much, but I don't have any more information than that. I honestly would check in with your physician on that if you really are concerned. But again, I did not find a wealth of information on it. Now, certainly the data that I read was based on cohort studies, based on observational data, not based on double-blind placebo-controlled studies of any type, but again, based on hospital records that have been gleaned over the months as this pandemic has been ongoing. So be careful about taking too much to that because observational studies, while very, very important, they're not based on double-blind placebo-controlled studies as far as I'm aware of when it comes to this issue. So I honestly would take this somewhat with a grain of salt. If there's a tremendous concern, please check in with your healthcare practitioner.
Next question. When testing for coronavirus antibodies, there are some tests for the antibody against the nucleoplastid part of the coronavirus and other tests that test for the spike protein. Could you speak a bit on this?
What was the last part, Stacy? Oh, could I?
And other tests that test for the spike protein. Could you speak a bit on this?
Yeah, I'm not an expert on various tests, so I'll just caveat my comment with that. But I do think that these antibodies that I have read about specific to the spike protein are kind of the ones that have garnered the greatest amount of literature. So I'm very enamored with antibodies to spike, but if there's antibodies to the nucleocapsid or other parts of the virus, I'm sure that those are viable as well. But again, I'm far from an expert on the various tests that are being used to evaluate antibody titer.
If you've already had the actual virus, would you need to be vaccinated?
100% yes. Check with your doctor, check with your physician, but everyone, physicians I've spoken to, colleagues of mine at Pfizer, and from what I've read, even if you've had the virus and you clearly have antibodies, please go get vaccinated. You don't know what the level of antibody titer is. You don't know how much dose of the virus you got to indicate that you were positive. I have not read of a single contraindication to getting the vaccine once you've been infected with the virus and in fact have antibodies. Please get the vaccine, check with your doctor.
Can you please make clear the reports of taking acetaminophen or any other aids during the day of getting vaccine?
Was that acetaminophen, Stacy?
Yeah.
Yeah. Boy, there is some very interesting information about taking prophylactic acetaminophen or other pain relievers prior to getting vaccinated. And in fact, to my surprise, I did see some literature that said that that was not necessarily something that you should do. Very surprising to me. I was not aware of this. My answer to this question, I've given you my understanding that there may be an issue. Please check with your doctor. 100%. Don't take acetaminophen. Don't take ibuprofen and you're getting ready to get vaccinated. Please check with your healthcare practitioner before you do that and get their opinion of it.
How does the vaccination scenario look like for children?
Yeah, the data is not quite there yet. As you saw from my presentation, children typically get less severe reactions to COVID-19 if they are infected. I did show you the Kawasaki-like syndrome that can happen in very young individuals, 5 or less years of age. The data, as I understand it, is not quite there yet to support vaccinations in young children. Therefore, it is my understanding that that is not available to them. No question that down the road, as more clinical trials are done, that demographic will certainly open up. Again, very important that you talk to your healthcare practitioner about any concept of vaccinations for young children.
For those who have refused to take the second dose, are they more at risk, and will they lose their initial immunity?
I don't know that they'll lose their initial immunity. Two things would, I believe, happen. Don't forget, with both doses, they're theorizing about 1 year of protection. If you only get dose one, you may be that time frame for being immune could be far less. But what's really important is you're not getting the 95% protection effectiveness. You only got, in theory, one dose, around 50%. You're 50-50 about getting a severe reaction. And Stacey, one thing I want to mention that I probably should have, but real quick, vaccines, at the end of the day, keep people out of the hospital. The last thing you want to do is get COVID-19 and end up in a ICU unit. These vaccines clearly are keeping people from developing a severe symptoms and keeping you out of the hospital. If you get dose one, you're 50-50 about getting a severe reaction, and who knows how long that immunity of 50% would even last. Oh, that's a mistake. Don't go for dose one and then don't go, and then don't get dose one and don't go for dose two. That's a mistake. That's not how, and at the end of the day, that's not how the clinical trial was done for Moderna and Pfizer. It wasn't like they gave dose one and then see you later. That clinical trial was done with booster doses in both cases. So you are outside of what's been clinically proven, and you really are not taking advantage of the vaccine in any way. So I have a big problem with that. I hope that an individual would not do that.
I think we have time for one last question.
Okay.
Would there be greater benefit to prophylactic acetaminophen in pregnant women, especially the third trimester, to avoid high fever and risk of miscarriage?
Yeah, I am not qualified to speak at all about pregnancy. This is one that I really would not give any input on at all. I have heard anecdotally that pregnant women should be vaccinated. This is so important. Please check with your doctor. Please check with your doctor. I was on a webinar where physicians from Stony Brook did talk about pregnancy, and they did come on quite strong about getting vaccinated. But with the way you just described it, Stacey, with regard to some ancillary medical conditions that might be involved in a third trimester of pregnancy, there could certainly be ancillary issues there. Please, I cannot give you any insight other than to please check in with your obstetrician and other physicians that are in your orbit to find out the best course of action for you when it comes to being vaccinated.
Great. Thank you, Dr. Clair. If you do have any more questions, please email me and I will forward them to Dr. Clair. And this way we can try to get all the questions answered. We are 13 minutes over time right now, and I just want to be respectful for that. Dr. Clair, do you have any last thoughts?
No, thank you so much, everyone who called in. Again, thanks to Stacey, Bill, and Rachel from St. John's. I really appreciate you taking the time to listen. And Stacey, I do apologize. I went a little bit long, but I'm happy that we were able to get through some of the questions as well. So again, I have a great gratitude for being able to participate today. Thank you so much, Stacey.
Of course, and no need to apologize. This was an excellent presentation. And
Thank
with
you.
that said, I just want to say thank you to Dr. Clair once again for this wonderful presentation. For Dr. Clair's full bio, please go to stjohns.edu/CF webinars. Here you will also find a schedule of upcoming webinars and past recordings. I do hope that all of you will join us tonight at 7 p.m., where we will be interviewing Mural Javadafar, Assistant Strength and Conditioning Coach for Super Bowl champions, the Tampa Bay Buccaneers. In the meantime, have a great rest of your day. Take care, everyone.
Bye-bye.
Bye.